नहमदुहु व नुसल्ली अला रसूलिल करीम amma ba'd a'udhu billahi minash shaitanir rajim bismillahir rahmanir rahim. As most of you know, I am Rehana Ilahi, the Chief Nursing Officer of Shaukat Khanum Memorial Cancer Hospital and Research Center. On behalf of our organizing committee, I welcome you all to this prestigious and educational event of Shaukat Khanum Memorial Cancer Hospital. This is 24th Shaukat Khanum Cancer Symposium. And inshallah, you will see many scholars and young nurses from Pakistan and international institutions will be participating and enlightening us with their knowledge and work. To start the program, I would like to call my chairpersons and mediators to the stage. We have with us Dr. Raisa Gul, Dean, Faculty of Nursing, Shifa Tamir Millat University, Islamabad. Dr. Raisa, please come to the stage. Our second mediator and co-chair of the program is Mr. Nasir Khan, the Director of Nursing, Shaukat Khanum Memorial Cancer Hospitals. Nasir, please come to the stage. And our third mediator and the moderator and the co-chair of the program is Ms. Farida Khan, Associate Director Nursing, Shaukat Khanum Memorial Cancer Hospital. So dear colleagues, without wasting more time, we will start our program with the recitation of Holy Quran. And for that, I would invite Mr. Yusuf, one of our nurse intern, to come to the stage and recite verses of Quran for us. Mr. Yusuf.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. In the name of Allah, the most gracious, the most merciful. Read, in the name of your Lord who has created all that exists. He has created man from a clot, a piece of thick coagulated blood. Read, and your Lord is the most generous, who has taught the writing by the pen. He has taught man that which he knew not. Sadaqallahul Azim.
Technology can deceive you at any point. Assalamu alaikum and good morning to all of you. It is my great pleasure and honor to be here. So we, this morning, the first virtual talk by who is in Professor Vanderbilt University School of Nursing, Nashville, USA. And her topic is her or his, I believe her. And her topic is use of artificial intelligence in nursing academia. Thank you. So can we have the
Video, yeah. So they must be setting or something. Okay, thank you.
In the United States. Thank you so much for inviting me to be with you today. I'm very excited to speak with you regarding the topic of use of artificial intelligence in nursing and academia. I have no conflicts to disclose. Some of the virtual simulations that I'm going to share with you were supported in part by the Nurse Education Practice Quality and Retention Simulation Education Training Program grant. The content doesn't necessarily represent any official views or policies or an endorsement by HRSA or HHS. During this presentation, we're going to think about some overarching principles associated with ethical and responsible use of AI in nursing academia. We're going to think about some opportunities for AI use in nursing education and explore applications of AI for clinical simulation and automated feedback. We're truly in the midst of a significant shift in nursing academia. We're focusing even more on readiness to prepare nurses for complex healthcare systems. And we're faced with the emergence of AI into not only our healthcare system, but also our everyday lives, and increasingly within nursing education. As we consider the integration of AI in nursing academia, I'd like for us to think through this acronym, Nurses Lead. Yes, let's start with N, which stands for Now in Nurses. Now is the time for us to explore generative AI. And then as nurses, we are ready to lead the way for ethical and responsible use. U is for unique, and generative AI truly is unique, which is what is making so many innovative and creative use cases possible. R is for responsible use. We want to be thoughtful and intentional regarding our use, which AI-based tools that we're using, what information is being uploaded into these tools, collaborating with our technology experts, considering our AI governance and institutional policies and laws that govern the use of AI. We want to think about developing our AI competencies, both as nurse educators and helping our students to develop AI competencies as well. And S is for safety. We know there are limitations and risks, and we want to identify them and develop a plan to mitigate those risks. For example, we can consider the risks of potential for bias and privacy issues and errors and inaccuracies. E is for ethics. We want to be guided by those ethical principles that are such a core aspect of the nursing profession. And then S is for solutions. As we identify the limitations and challenges with AI, let's be part of the solution and figure out how we can leverage and harness the benefits of AI and mitigate the risks. L is for leadership. We can lead the way in establishing best practices and being part of AI governance and the implementation for ethical and responsible use of AI-based technologies. E is for emphasize. We should emphasize the importance of human oversight and confirming all AI output. A is for augment. So instead of thinking about AI as artificial intelligence, what if we think about it as augmenting our intelligence? Within this context, AI can augment or amplify our ability to be more creative and more innovative and really scale excellent ideas much more quickly. D is for drive. We can drive forward innovation and transformation in nursing academia, while also ensuring that this is done so in a way that advances the responsible and ethical use of AI-based technologies. Now we're going to think about some overarching principles for the use of AI-based tools. Many organizations, including Vanderbilt University School of Nursing, recognize that generative AI is a valuable tool, but it must be used appropriately, ethically, and responsibly. We must develop competencies as nurse educators, and our learners must develop AI competencies as well. Users of AI-based tools must comply with confidentiality and privacy policies, and keep in mind that anyone who uses an AI-based tool is responsible for that AI-generated content. It's important to analyze all AI output and consider the tool that's being used, because we ultimately are the ones that are responsible for the accuracy, impact, and compliance with relevant laws and policies. We should keep in mind several important privacy considerations with the use of generative AI or any AI-based tool. Here's an example of a data classification framework. We have 4 levels, levels 1, 2, 3, and 4, with level 1 being public, level 2, information for institutional use only, level 3 is more restricted, and then level 4 is the most critical. I do encourage you to look within your institution at your data classification framework, and then speak with your technology experts within your institution about how this applies to the use of AI-based tools and information that you may input into various tools. It's very important to review any privacy policies associated with an AI-based tool. You want to think about whether that tool is unsecure, whether it's public. Check privacy policies specific to whatever the tool you're considering, because certain data might not be appropriate for certain tools. Of course, it's essential to consider laws regarding personal health information and student information. Now we'll think about some use cases for AI in nursing academia. I want to share some use cases for generative AI that was published in an article by authors Malik and Malik. They have some great ideas for different ways we might use AI as a mentor, tutor, coach, teammate, simulator, tool. Obviously, we know AI is a tool, but it's a tool that might provide feedback, might provide extra practice, and may help learners and educators accomplish tasks. Of course, Malik and Malik remind us with this chart that even though there are benefits, there's also potential risks. So making sure to confirm and verify any AI output because of the potential for error. We're going to talk about the term confabulation and hallucination in just a minute, but also encouraging our students not to outsource their thinking, but to use AI in a way that might augment their intelligence and actually help them to think more deeply regarding whatever they're trying to do, whatever problem they're trying to solve. So AI can be wrong. There's the potential for errors and inaccuracies with AI. A couple of terms to know about are confabulation and hallucination. Confabulation is when AI misrepresents or distorts real information. For example, AI might cite a legitimate source but misrepresent its findings or apply them incorrectly. Hallucination is when an AI system totally generates information that's entirely fabricated. It doesn't even exist in its training data or in reality. For example, it might completely invent a medical condition or cite a study that was never published. One of the ways to minimize hallucinations is through a RAG, or retrieval augmented generation. And this aims to minimize hallucinations by providing the large language model with a reliable and relevant knowledge base that's outside of its static training data. This process helps to ground the model's responses in verifiable facts, making the outputs more accurate and trustworthy. Another potential use of generative AI is for personalized learning to enhance precision education and facilitate productivity for both nurse educators and students. AI can help students with personalized learning or precision education by promoting adaptive learning, providing them with automatic feedback, helping them make study tools much more independently and quickly, and really customized to whatever areas they need to focus on. And it may also be helpful with competency-based assessment, pulling together all the evidence of what they've done, where they might have gaps, where they have strengths, and helping them to see where they are and what are their next steps in order to attain competency. So AI can also be helpful for nurse educators and enhance our productivity. This may be accomplished through course creation or course adaptation. Course creation is something that we can already use generative AI for. We have a custom AI software at Vanderbilt that we use for purposes of creating assessments and developing case-based learning. And I have found that generative AI can provide a helpful starting point for quiz questions or exam questions. But I'll definitely caution anyone to make sure that you're closely reviewing the AI output, because I do have to do quite a bit of editing for the exam questions that I've seen with generative AI. Content adaptation, I think there's a lot more that we may see regarding the use of AI to adapt content and assessments to make it specific to each learner's needs as well as their preferences. Nurse educators are continuing to seek innovative learning strategies that provide evidence of learners' progress towards clinical competence. And over the past few years, I have had much experience with integrating AI-driven virtual simulations in a few of my courses and have been very pleased to see the positive impact overall on students' learning and their engagement and their development of clinical reasoning and some other key competencies. There are several potential benefits of generative AI in simulation, including interactive conversations. I found that generative AI was particularly helpful in virtual simulations to allow students to have pretty realistic back and forth conversations with their virtual patients that were avatars. It also helped to promote their critical thinking and clinical reasoning. You know, when you use AI, generative AI, everything's an option. What do you want to say to the patient? They're just sitting there waiting on you. So what are you going to say? Why are you saying it? What differential diagnosis are you hoping to rule in or rule out? How are you going to provide that patient education? And then immediate feedback. We have also used generative AI to provide immediate feedback for students regarding oral presentations in alignment with a rubric that we developed. Generative AI was also really helpful in providing students with immediate and customized feedback. So another project regarding AI-driven virtual simulation involved collaborating with AI and virtual simulation software experts to align a rubric that was developed by my faculty team in order to provide the students with AI-generated feedback immediately after they completed a screen-based virtual simulation in which they performed a history for a patient with an acute complaint. So a valuable learning activity that we do with our students is to practice oral case presentations. And they often practice their oral case presentations with a peer or faculty. But we designed a virtual simulation to allow them practice delivering the oral case presentation with an AI tutor and receiving automatic feedback regarding their performance that was structured specifically on a rubric that our faculty team developed. This feedback was quite detailed, and the students really liked getting both quantitative and qualitative feedback. So they could see their overall score, and then they could see their score in each of the major sections that we were working on, as well as what they did well and opportunities for improvement. Overall, the students really appreciated the opportunity to have this structured and immediate feedback. Their most common reaction was that it was helpful. And then we as faculty were also able to review the performance metrics for each student and as a cohort overall. And we were able to see they did quite well. And then over time, we were able to see their progress as they continued to practice this same key clinical activity or skill with different cases. There are many valuable benefits of these AI-driven virtual simulations, including accessibility. Students can access these simulations 24 hours a day, 7 days a week, just by logging onto a website from their laptop computer. And then after they receive this immediate feedback, they are able to review their score and see what they did well and where they have opportunities to develop. The standardization of the simulation experience is nice. And then the consistency that the students had with the immediate feedback that was AI generated was nice because it was customized and based on a faculty developed rubric. Development of the AI-driven virtual simulation with the automatically generated feedback did take a lot of time to customize. So this was the one where the students presented an oral case presentation to an AI tutor. And so I took the rubric that I had helped develop with my team that we used to evaluate our students when they presented an oral case presentation to us. Well, we needed to adapt that rubric so that it could be used by the AI model. So the original rubric was closely adapted in order for the AI model to understand how to mark the conversation transcripts effectively and consistently across multiple interactions. Any adaptations to the rubric were made based on testing in order to determine what supports the model in producing the best outputs for student feedback. Well, it's an exciting time to think about the integration of generative AI in nursing academia. We're going to think about the opportunities, but keeping in mind the limitations and challenges so that we move forward towards responsible and ethical use of AI-based tools. We can think about ways that AI is used more as augmented intelligence and less as artificial intelligence. We'll develop AI competencies as nurse educators and encourage our students to do the same so that we are actually thinking more instead of thinking less by using AI. And so that there is not an over-reliance and erosion of skill. Because ultimately we know how critical it is that our learners develop these skills to ensure that they're prepared to deliver the highest quality care to those they will serve. AI is definitely changing quickly. Who knows what we'll be talking about in a year or maybe even a few months. But we can collaborate to optimize uses of AI and leverage its benefit while also keeping in mind the risks and the challenges. Together, I think that we can help advance the ethical and responsible use of AI in nursing academia. Thank you so much for your time and attention. It was an honor to be with you today. I hope you have a great rest of your day.
So thank you very much, Angel and Merton, for a very enlightening talk. I really appreciated the very creative way of interpreting the term or the word nurse lead, which is very pertinent in the context of AI. We learned about the several advantages as well as the cautious use of AI. And I was very pleased to know that for a big number of students, this is a solution that we all worry about. So, good. It's really, I was pleased to know that. And I will say that perhaps our student will teach us better how to teach. So from a flipped classroom to a flipped learning model is something that we should look forward to. Thank you. So our next speaker is Siobhan Shiobon. Okay, Shiobon Connor. She's a senior lecturer at King's College London, UK. Her topic is also on the use of artificial intelligence in nursing practice. Thank you.
Lovely. Good morning, everybody. Lovely to see you all, and thank you for coming. And this is my first time in Pakistan and my first time in Lahore, so I feel very welcome and well looked after. And I also really love your weather. It was cold and raining when I left London on Wednesday, so I'm very happy it is warm and dry in Lahore. So I'm going to talk to you today about artificial intelligence in nursing practice. So I'm currently a senior lecturer at King's College in London, and I also have an adjunct associate professor role at Western University in Canada. Is it a little bit lower? Turn it off completely. Yeah, I might just stand back a little bit if that's. Is there a way to turn it down? Thank you. I'll just stand back a little bit. Great. Is that a bit better for everybody? Good. Lovely. So, yeah, and I also have a voluntary role with Sigma Nursing, and I'm a UN liaison with them. So we're very lucky in the UK. King's College London is ranked top in the world for nursing in terms of research, and we have a lovely campus in central London where we have our nursing faculty. If you ever come to London, please let me know. I'd love to show you around. It's a really beautiful city, similar to Lahore. It's got lots of culture and history and lots of really nice food, although yes, our weather is not as good as Pakistan, I'm afraid, but it is a very nice place to visit. And it's a great place to work as a nurse and a nursing scholar. I also just want to mention a wonderful nursing association called Sigma Nursing. There is many chapters of Sigma Nursing all over the world. It's a scholarly association for nurses who do research, and there's also a chapter or group here in Pakistan. So if you're not already a member, I'd really encourage you to join Sigma Nursing. It's got lots of resources. It's got funding for research. It's got conferences you can attend for networking opportunities. And it runs two of the top nursing journals, the Journal of Nursing Scholarship and World Views of Evidence-Based Nursing. And it's got lots of funding and opportunities for nursing scholars. So please do think about joining Sigma. I've been a member of Sigma for over 10 years, and I've benefited hugely in my career by being part of this wonderful nursing organization. So this is what I'm going to talk to you about today. I'll start by talking a little bit about the history of artificial intelligence and where it's come from. And I'll also talk about some of the techniques that are used in AI. And Angel kind of mentioned a few or hinted at a few earlier in her presentation. Then I'll mainly talk about AI in oncology nursing, since most of you, I think, work in that field. And then I'll finish up by talking about how cancer nurses can use AI in their daily practice and some of the things that are happening in the UK in that space. So just very briefly, a little bit of background. Artificial intelligence comprises a whole suite of advanced computational techniques that are applied to digital data. And AI is very broad. It's trying to understand all different aspects of human intelligence. So it can look at things like abstract reasoning, knowledge representation, learning, autonomous decision-making, communicating in natural languages, and also sensing and interacting with the world around us if you're interested in maybe robotics or maybe chatbots or gaming if the world is virtual. And there's lots of definitions of AI. And there's no real agreement about what it means because it's quite complex. But I quite like this description from an EU report that kind of summarized and synthesized many definitions of AI because it's not too technical and it's easier to understand. But it's a combination of software and hardware systems with the goal of mimicking some aspect of human intelligence, and it combines both structured and unstructured data and uses a whole range of techniques, mainly symbolic rules and predictive modeling, which I'll talk about in a minute, to help us understand the world around us and interpret and make the best of it. So that's a really nice description of AI. And artificial intelligence actually began many years ago, back in the 1950s, after the end of the Second World War, when there were breakthroughs in encryption and computing by Alan Turing and others, and that inspired other people to really explore AI. There was lots of experimentation and dead ends in the 60s, 70s, and 80s, and it wasn't until the early 1990s when advanced computational techniques like machine learning and natural language processing started to emerge. And since then, AI has really been expanding rapidly. And now that we're in 2025, we have lots and lots of AI tools and AI models, and some people might say we've too many, which I kind of agree with, and we will have many, many more as the years go on. And interestingly, when I started searching about AI in nursing, I found some research from the early 1990s. So this is the earliest study that I could find from a nurse who was talking about using neural networks, which is an AI technique to help nursing diagnosis. And it was published in 1993, and the nurse was based at Boston College in the USA. So even way back then, some nurses were really on the ball in terms of informatics, and the rest of us are just catching up 30 years later. So just very briefly, as I mentioned, there's lots of different techniques that are used in artificial intelligence. So you might come across things like fuzzy logic, expert systems, Bayesian networks, etc. But the two most popular and widely used techniques are called machine learning. And these are all the algorithms that are used to learn from data to build predictive models. And I'll talk about some of those in a minute. And there's three different types of machine learning. There's supervised learning, unsupervised learning, and reinforcement learning. And there's lots and lots of different algorithms that fall into these three categories. And they all work in different ways to do different things to the data that you have. And then the other big category of AI is natural language processing, or NLP. And again, this consists of a whole suite of different computational linguistic techniques to help us understand text and voice data. So NLP is really useful in nursing because we capture lots of data that's unstructured, our nursing notes about our patients and about what's happening in our hospitals. All of that data is unstructured, and NLP is very good to help us analyze and understand that. And the other aspect to do with AI, which is important to remember, is that AI kind of overlaps with neighboring fields because it shares some techniques in common with data science, with text mining, and good old-fashioned statistics. So it can be a little confusing when you start reading about AI initially because you'll come across these other fields as well. But they do have some things in common. So now that we know a little bit about AI, I want to mainly focus on what's happening with AI in oncology nursing specifically. So myself and some colleagues did a systematic review a year or two ago to look at all the research that had been published on AI in cancer nursing. I'm not a cancer nurse myself. I specialize in informatics, but Amy and Janelle, Louise, Luyen, and Fatima are all cancer nurses. So yeah, they contributed their expertise to this review. And I'll talk about the results that we found now with you, so hopefully they're of interest to your own practice. So when we did the review, we were thinking about three different things. We had three questions that we wanted to try and understand. First of all, how is the AI being applied in all the different areas of cancer nursing? And how is it being used? Then we interested in how involved cancer nurses were in the research itself, and then also look at the limitations and risks of AI, because it's not a perfect technology. It does introduce new risks and limitations that we need to be aware of as practicing clinicians, because it could potentially have an impact on our patients. So I won't bore you with the methods. We use the standard approach to doing kind of a scientific review, search databases over a 12-year time frame using all the key terms. And we were just looking for real-world studies that used AI and not anything that was prototyped or simulated. So we excluded some studies that fell into those categories. We found a couple of hundred results, and after screening, we ended up including 20 research studies in the review. And it's just quite a descriptive review. There was no RCT, so we couldn't do any meta-analysis, and most of the studies were quite descriptive, so we just summarized them in that form. So just very briefly, this is just an overview of the kind of geographic spread of the research. Most of the studies were conducted in China. There was 3 in the USA, 1 in South Korea, and then 1 in Denmark, Finland, Iran, Italy, Japan, Switzerland, Taiwan, and the Netherlands. Unfortunately, there's plenty of parts of the world that aren't doing AI research at the moment. Parts of South America, Africa, plenty of parts of Europe as well, and Central Asia. But this review was published maybe a year or 2 ago, so I'm sure there are countries now that are contributing research in this area. So just very briefly, the study characteristics, there was a whole suite of cancer patients involved in the studies, from bladder and breast cancer to skin cancer, head and neck cancers, gynecological cancers, etc. But the patients that were involved were typically older patients, 50 or over, but there was one research study about a pediatric population. There was a whole suite of AI techniques used, mainly machine learning techniques like decision trees, random forests, support vector machines, neural networks, etc. And the study designs were merely quantitative in nature, taking data sets from an electronic health record in a hospital system of some kind. So coming to the results that are of interest in terms of cancer nursing. So most of the research obviously was focused on direct patient care, about 17 of the 20 studies. And again, they were mainly building predictive models to try and identify risk of developing certain symptoms or risk of developing certain diseases in the cancer domain. 1 or 2 studies did focus on nursing administration and management, and I'll give you 1 or 2 examples of those. And we didn't find any research about using AI in cancer nursing education or in the policy arena. So there's lots more detail in the published review about the studies if you want to have a look at them, but I'll just talk through 1 or 2 practical examples so you can see what I mean. So this is a really nice study that was done in South Korea, where they built a predictive model using a data set from a hospital, and they were interested in the length of stay after post-operative surgery for ovarian cancer. And so they used a couple of different machine learning techniques to develop the AI model based on their hospital data set, and improve the accuracy of predicting how long patients are going to need post-op care. And then they were hoping to use that model to figure out, what patients are more at risk of staying longer, and how many nurses do we need to have in a cancer ward to make sure we can deliver good quality care to those patients. And the model was relatively accurate. And then I think they were hoping to use this further in the cancer hospital. This is another nice example from a study from Taiwan, where they used data sets from a health insurance database to develop a predictive model for nurse staffing in terms of cancer care over a 10-year period. Again, they had a much larger database. It was several thousand records. They used a number of machine learning techniques to develop a predictive model, and then rolled out the model with nurse managers to see if they could predict nurse staffing in different areas of cancer care. So that's another great use of AI and machine learning techniques. So then we were also interested in how involved cancer nurses were in the research itself. About half of the studies were actually led by cancer nurses, which was great. And the other research studies were led by colleagues in computer science, medicine, engineering, pharmacy, and health services research. So it's great to see that cancer nurses are doing this type of work, and there's more and more cancer nurses doing AI research all the time, which is great. And I'd be really curious if there's anybody here today or any nurses that you know of in Pakistan who are doing AI research in cancer. So this is one example of a group of nurses from China, and this piece of research was led by nurses where they were developing a predictive model for thromboembolism to see if they could predict the risk of patients developing this condition while they were in hospital. And again, they used a hospital-based data set of various factors and used some machine learning techniques to build a predictive model to identify patients at risk of developing VTE. That's a really nice study that was led by nurses in oncology. So coming to the limitations and risks of AI, I know Angel mentioned a few in her presentation, but just to go into them in a little bit more detail in terms of cancer nursing, the quality of the data thing is the most important aspect of building a good AI model and having a good tool, because if your underlying data set is poor quality in any way, then it's going to affect the results of the outputs that the tool produces. So this might be things like using self-reported measures because they may not be reliable, using particular clinical measures that may not be used in other hospitals or other regions and parts of the world, which means that your model is not transferable outside of your individual hospital. A lot of data sets might have retrospective data that might not reflect current trends. For example, when COVID came along, a lot of the initial modelling around COVID was kind of off by 20–30% because it was based on data sets from infectious diseases that were not quite the same as COVID. So it's really important, especially for infectious diseases, that the data set is up to date as much as possible. And, you know, cancer is moving on all the time. There's different cancers developing at different rates. So having good quality, up-to-date information in our hospital systems is really important for building good quality AI tools that nurses can use. Angel also mentioned about the issue around bias. And again, that comes from poor quality data sets that don't adequately represent the patients that we look after every day. So for example, in the UK, we've got a lot of problems. We've got quite a diverse city in London. We've lots of data about some patients and we've very little data about patients with different ethnic backgrounds from certain populations. Our homeless population is very much underrepresented in the data that we have, and therefore the AI models and tools that we build don't really tell us anything about certain groups of people. So we need to keep an eye out for AI bias appearing in the results of any of the models that we develop and the outputs, you know, what they're telling us we should and shouldn't be doing. Lack of transparency is another issue. So this is to do with black box AI, where some of the techniques like neural networks, we don't fully understand how they work. So that might cause trust issues if nurses and doctors are being asked to rely on these new tools to make decisions, and yeah, we don't really fully know how they work and come to the answers that they give us. And then Angel also mentioned some privacy issues around the privacy of our data and if our data sets are being handed over to commercial AI companies for their use, and made sure that that data is used appropriately and that the correct regulation is in place to protect patients and patient data when they're being used to build AI models. So unfortunately, our review obviously was quite small. We only had 20 research studies, and so we weren't able to report on all the issues to do with AI, but there's some really good reports from the WHO and the United Nations and other organizations that go into a lot more detail about the limitations and risks of AI. So things like autonomy. So there's obviously a concern that AI might replace nurses or nurses' decision-making, or that AI applications like robotics might take over our jobs completely and replace us as humans. I personally don't think that's going to happen, but there is some concern among people that, yeah, nurses will be replaced with robots, which, yeah, I think is really silly. There's also the safety issue that I mentioned. If the models aren't 100% accurate, and who is responsible for the decisions that are made off the back of those models? Transparency and explainability. As I mentioned, some of the AI techniques are not clear in how they work, and that can lead to concern about the decisions that are made and if we should really rely on them 100% in terms of our decision making, and who is accountable if something goes wrong. It always goes back to the professional that makes the decision. So it's really important, if you are using an AI tool, that you use your clinical judgment as well, because your AI is never going to have all the data on your patient. It's only going to have the data that comes from your hospital record. And there's lots of data that we cannot put into our systems for various reasons. And that's where you come in as a nurse, is to use your understanding of the patient and your clinical judgment and your AI tool to make the best decision for the person that's in front of you. There's also kind of equity and fairness issues, mainly to do with algorithmic bias, and also the sustainability of AI, because AI is very expensive. It's not feasible for every country in the world to introduce AI-based systems because they cost a lot of money, and they also require huge amounts of energy and water to keep those computer systems running 24/7 and keep all the technical equipment cool and operational. So it is a very, very expensive option. And the WHO is pushing for more equitable use and distribution of AI to make sure that low middle income countries can still benefit from AI, even though it's hugely expensive to introduce it. So these are all things to consider as a practicing nurse. So just to kind of come to the recommendations from our review, firstly for nursing leaders, and I know there's many nursing leaders in the room, to try and strengthen capacity in the workforce to collect good quality digital data about cancer nursing and our patients. So this might mean investing more in electronic health records and mobile ways of working so that we can collect data at the point of care, and it's good quality and up to date. And that'll help us build good quality AI models and AI tools and make sure that they're available, that data set are available for research as well. For nurse practitioners, I think there's lots of opportunities to seek out ways to introduce AI into your practice and to get involved in AI research by working with colleagues in computer science, in medicine and other disciplines, because AI is a very interdisciplinary field and we need lots of expertise from different sides to contribute to that. Nurses can also become involved in AI governance to make sure that AI models and tools are developed and applied appropriately and that vulnerable patient populations aren't disadvantaged by the use of AI. For those of us who work in education, we need to create curricula on AI and teach our nursing students and our nurse practitioners how AI actually works and all the practical applications. And I've started to do that at my university. And I'll show you one or two examples in a minute of that. And for those of us who do research, obviously to conduct rigorous interdisciplinary research to understand if AI is really going to help us or not, as well as to understand its limitations and risks and how to actually introduce it into a complex setting like a hospital where it's going to affect how nurses work and do their job every day. So that's hopefully a nice overview of AI in oncology nursing. And I just want to talk about some developments that have been happening in the UK in the last year or two, and they've been happening worldwide as well, because AI is moving on all the time. And obviously we've had lots of generative AI tools since ChatGPT arrived at the end of 2022, early 2023. And there's been tons and tons of research about how to use large language models and ChatGPT and all the other tools in cancer nursing. So they can be used in lots of ways for patient education, for educating staff. Some of the research has also used them to support decision making when you've got multidisciplinary teams and trying to make complex decisions about complex cases. So there's lots of interesting ways that people are exploring ChatGPT and other Gen AI tools in cancer research and cancer nursing. I know from nurses working in the UK that they're not using these tools in hospitals just yet, so it's still very research oriented to try and understand how we can use them best. And they don't always give you an accurate answer, so that's always important to bear in mind. But yeah, people are exploring their use in all sorts of different ways. And the other big change that's happening in the UK just this year is the use of AI scribing technologies, or some people refer to this as ambient AI. So this is a device that sits in the background and records the audio conversations that are happening between nurses and patients, or doctors and their patients. And then the AI technology turns that audio data into an electronic written record of the conversation. So the idea is that it speeds up the documentation and care planning and takes that workload off busy nurses and doctors who've got lots and lots of documentation to do. So these AI scribes are being rolled out in some of the hospitals in London at the moment, just to test them, pilot testing them in different wards to see how good they work, how good quality the documentation that they produce, and if they're worthwhile being rolled out on a large scale. And I think these, so far, they look like they're good quality, and I think they can speed up the work that we do and make it better quality. So I think you'll see these coming into cancer nursing very, very soon, because they're already being rolled out in hospitals in London, and it looks early indications are that they're working well, and they're quick and easy for people to use, and they produce good quality records, which is great. So lastly, I just want to talk about a bit on the education side, because I think it's great that practicing nurses know about AI, but if we're to make sure that all nurses know about AI in the future, we need to educate our nurses properly. My out of time. Yeah, so I'm just teaching my students at King's, and that's my course that I run. So thank you very much for listening, and happy to take any questions now or later. Thank you.
Thank you, Shweebon, for highlighting the very interesting information that AI began his work 75 years ago, and today we have no choice but to accept it in our education and practice. It was also, the key message is that it is useful for nurses in planning and predicting the needs of patient care, and much more to go. Thank you very much. Thank you.
So our next topic is for this day is patient and family empowerment strategies to fill the gap in cancer care services. And this talk will be given by Professor Dr. Raisa Gul, who is the Dean of Faculty of Nursing and Midwifery, Shifat Amiri Millat University, Islamabad, Pakistan.
Bismillahirrahmanirrahim. Distinguished guests, leaders of nursing, organizers, my fellow nurses. Assalamu alaikum and a very good morning to all of you. I'm very thankful to Ms. Rehana and her team to give me the opportunity to be speaking to this August gathering. I would also like to disclose that this topic is closely aligned with my values and belief about patients and their family in the healthcare system of Pakistan. This is the plan of my talk. Pakistan is faced with escalating cancer crisis, 185,000 new cases and 125,000 deaths annually. There is the high mortality rates could be attributed to the late stage diagnosis, limited oncology infrastructure, and workforce shortages. We have about 40 cancer care treatment centers in the entire country. And most of that, though our population, 60% population lives in rural areas, all the centers are in cities. I'm not sure if something recently happened, but this is the case to my knowledge. And so this is not enough to meet the needs of the patients. Fewer than 250 specialized oncologists are available for the entire nation. And we have an additional need of 2 million nurses. And despite of this need, we are very keen, I will say nurses themselves, but also the government is very keen to export nurses for remittance purpose. We can send them abroad. Given this situation, our focus is mainly on curative care compared to prevention and palliative care. We are situated in the world top opium and morphine producer region, but only 2% of patients have access to essential opioid pain relief. This is due to restrictive regulation and many misperceptions, including addiction. There is also lack of palliative care policy at national level. I'm just realizing that I did not look at how the animation is working. It is going upside down. So you have to bear with it. I'm just realizing it. We have over 870,000 individuals in the need of palliative care, but it is only less than 1% who receives it. There are also cultural and societal factors cultural norms often dictate that discussion about deaths are avoided. And I was just thinking when Shivbon was presenting that, this could be one area to, have this kind of conversation without intimidating the patients, and they could have those conversations. So family autonomy takes precedence over patient autonomy. Pakistan, a healthcare budget is used to be less than 2%. Even for this year, it is less than 1%. So nearly 70% of the healthcare expenditure are out of pocket, predominantly in the private sector, which many people cannot afford. Specific to nursing workforce, there is acute shortage, as I said already, at least 2 million. The numbers keep changing, but that is the latest from the Ministry of Health and the Pakistan Economic Council report. There are strong push and pull factors which leads to high turnover. And the recruiters specifically, I will say, rob hospitals who are JCI accredited. With regards to the competence of nurses, wide variations are observed in the nursing education, particularly the shortage of appropriately qualified faculty and clinical learning opportunities. On-the-job training and continuing education is rare, except the few good hospitals. It's an issue. The employer and public both have higher expectation, but without due facilitation and rewards. Regulatory oversight is another issue with regards to the continuing education or nurse to patient ratio. With regards to preparation and expectation from oncology nurses, all the research that you see on this slide is mostly from Pakistan. So there is small number of nurses who have specialized training to work in oncology setting. As I said earlier, orientation of nurses in hospital is not a norm. Most of them are not involved in breaking the bad news about diagnosis or prognosis, but they are expected to provide extensive care for patients, and patients and their family member do feel comfortable asking questions from nurses about their care. Unsatisfactory practices and application of knowledge into practice remain a big concern. The lack of skills such as effective communication, breaking the bad news, and managing complex system leading to unmet needs of patients. Patients and their family member usually ask questions and seek clarification from nurses. Working in oncology is emotionally demanding work, which has implication for nurses and their clients. With regards to patient awareness and perspective, cancer is understood as life-threatening and deadly condition. The treatment is long, complex, and expensive. Access to cancer is limited, as we said already. Overall, patient quality of life is reported to be poor. Emotional and physical well-beings are particularly compromised. Patients experience severe stress and anxiety. Awareness level is very low and could be dangerous with consequences. And here I would like to give you two examples. One from the study of Jetha et al., which was about the external prosthesis after mastectomy. One of the patients reported that she had developed severe infection because she could not afford the proper prosthesis. So she used pouches filled with bajra and, sort of lentil, I've forgotten something, it's called millet grain or some pearl millet, something like that, bajra. And in that, it developed worms in it, and that, affected the wound. So you could see so serious, because one is affordability and again is the lack of awareness. Likewise, another study which was done in women who were undergoing radiation therapy after breast cancer. In that, several of them reported that they did not take bath, and this study was done something in the month of like June, July. This study was done. So they were not taking shower because their skin was marked for radiation, and they were told that they need to take care that it is not erased. But there was no further education. So how these women will take care or shower? And some who required it, who had no choice to do that, then they marked themselves with some marker, which again could be very dangerous. So let's talk about paradigm shift in care. The current evidence from world consider quality of life as the primary goal for cancer treatment in patient survival. And modern oncology services prioritize patient empowered, a shift from paternalistic care to partnership model that improves satisfaction and clinical outcomes globally. In Pakistan, empowerment must target the entire family unit as the primary decision maker and support system, ensuring informed and collaborative care. Here, nurses, if appropriately prepared, can help the patients and family caregiver empowerment in several ways, as I'm showing on this slide. That is from hospital to home care. Though we talked about the number and competence, but I'm talking about that they have to be properly educated. Nurses are in a very good position to empower the patient and family, because they are in direct and continuous interaction with both patients and their family caregivers. They have the ability to observe and identify patient needs. They're responsible to coordinate care and collaborate with stakeholders, including physicians or surgeon, allied health personnel, support services, and above all, family members. This slide shows some evidence that how nurse-led interventions are conducted in Pakistan. Though predominantly at this stage, nursing research in Pakistan is at, I say, descriptive level or correlational level. And I'm also acknowledging here that this is not all the studies, but this is the studies in, my students were involved. So I'm taking pride in that and sharing it here. So the first study, it was a 6 weeks intervention. This included individualized education and support before, during, and after chemotherapy in patients with breast cancer, which shows a significant improvement in the patient overall quality of life, including physical and emotional well-being. It was also a very good source of creating awareness for the entire family. Individualized education with support in CA breast patients undergoing radiation therapy. This was another study, and that shows significant reduction in the patient anxiety and depression. a very recent study, the students, inshallah, going to defend in next week. She created an educational video game for children who is receiving a treatment for cancer. And again, this study shows that it has enhanced their knowledge and skill about symptom management and improved their self-care and coping abilities. The most interesting part is that this video game was developed with the input of children and their parents, right? So very contextually designed. And then, it was implemented and the outcomes are really positive. And this is at this stage, this video game can be used in other centers. So again, something that it requires a lot of effort initially, but once it is done, it can be used in multi-centers. However, strategies for empowered will also need systematic approach to patient and family education. I mean, right now we are doing it, but it's at random. So we need systematic approach. Given the high mobile penetration in the country, there is a chance to scale, these efforts. Welcome, Professor Erica. You can come to the front. Utilize mobile health application for self-management at home and provide interactive support and remote monitoring. The use of digital instruction through mHealth and telehealth in local languages could be very useful. Intervention to enhance the skill of family caregiver for their patients' care and their own care as well, because they also experience stress. So these are necessary, and nurses should take lead to provide standards and guidelines for best practices to support family caregivers. We also need to advocate for specialized nurses in oncology and for their continuing education. We also need to enhance their research skills and evidence-based practice. So how, given all those needs, I'm going to disclose it to you with happiness, I will say, that the Shifa College of Nursing, in collaboration with Shaukat Khanum team sitting here at front, inshallah, we are going to start a postgraduate diploma leading to MSCN. And I will just elaborate a little bit that to date, we have mostly two tracks in MSCN. That is education and critical care. And the way it's offered, that we have core courses first and then specialized. In this approach, we are going to flip it. What inshallah we will do, that we will offer the specialized courses first. And if someone wants to exit after those courses, they can exit with a postgraduate diploma. And if they want to take a break and want to come after a year, they can come back, do the some research work, and they could exit with a master's degree. So this is something that we have adopted to, that as we move from diploma to degree education in the country. Previously, we used to have 1 year specialization, and people felt that, why should they take these courses, because they think if they have done degree, diploma has no value. So it used to be post basic diploma. It will be now postgraduate diploma, right? So I hope you find it appealing. So one of my recommendation, I hope it is not a surprise for you, Ms. Rehana, I feel, given the lead of Shaukat Khanum in cancer care, and also the value that Shaukat Khanum has shown for nurses, as well as your excellent infrastructure for research, I would like that you create a center named Education, Research and Advocacy Unit for Patients and Family Empowerment. And through this initiative, you can collaborate with other cancer care centers, whether in public or private sector. In that, we can create contextual knowledge for effective patient and family caregiver education. We can decide for appropriate themes for research and also build the repository for nursing research. Even preparing this presentation, I thought even we don't have much, but still there is a good number of work already done. We have to systemize it. And we can collate all the available resources for easy accessibility and use it for advocacy of patient and family caregiver empowerment. In conclusion, given the escalating burden of cancer and limited availability of healthcare resources in Pakistan, it is imperative for nurses to enhance their knowledge and skill and to empower patients and family. This approach is important for better clinical outcomes, enhancement of patients and family satisfaction, as well as the efficient use of available healthcare resources. Thank you very much. Thank you for listening.
Thank you very much, Dr. Raisa. Definitely, you have highlighted the burden of cancer disease and challenges, especially related to the nursing workforce. And indeed, nursing have a central role while shaping the patient and family empowerment model throughout the transition of care. Thank you very much again, and also sharing the future of educational track, especially in MSN, which also includes oncology. Thank you.
The final speaker of the day is our own Chief Nursing Officer, Ms. Rehana Ilahi, visionary leader, educator, and clinician. Ms. Rehana is going to walk us through her research study titled as Exploring the Nurses' Mental Wellbeing, Perspectives from Clinical Nurses and Nurse Leaders in a Cancer Setting. Thank you.
Assalamu alaikum. Thank you very much again. And Dr. Raisa, your recommendation is very well taken. And inshallah, as I said, Jada Bole Kunda Khole will come to you for mentorship. It's a lifetime mentorship, will never end for me at least. Exploring the nurses' mental well-being perspective from clinical nurses and nurse leaders in a cancer care setting was a study conducted by senior nurses of Shaukat Khanum, including myself. So outline of my presentation would be based on these topics. In introduction, I must say nurses and other healthcare providers need to perform their level best and their highest level to meet the need of the patient care. They must work upfront in life and death scenarios and show stability, knowledge, and competence. Nurses, by virtue of nature of their job, have to face multiple stressors in their daily work life, which can impact their mental health and may lead to several consequences, which are listed here as poor job performance, poor patient outcome, decreased patient satisfaction, and reduced nurses' job satisfaction. Nurses' mental well-being is a crucial concern for the healthcare system stakeholders and the organizational leadership. Nursing and the non-nursing leadership may promote it by recognizing nurses' contribution to the healthcare system. So the research study, the objective was to explore the clinical nurses and nurse leaders' perspective about nurses' mental well-being. And there were two questions: what factors in working environment affect nurses' mental well-being? What initiative can be taken by nurses leaders to enhance the well-being of nurses at workplace? The methodology, which was used, a descriptive, exploratory, qualitative study at both campuses of Shaukat Khanum, Cancer Hospital Lahore and Peshawar. We choose purposive sampling, which include 10 to 15 nurses in each group of clinical nurse and nurse leaders. The clinical nurse definition in our context is a nurse working 50% and more of its time in a direct patient care. So that includes staff nurses too, official shift leader and team leaders. So the clinical nurses working at Shaukat Khanum for the last 1 year were included in a sample. Those nurses who are serving their notice period have gone through certain disciplinary actions, have faced mental health issues, and family issues were excluded from the study. In-depth interviews were conducted following study guide. Qualitative data analysis was performed by using Atlas software version 24, and all these steps were followed. In the results, in demographic data of 29 nurses and nurse leaders collectively, the age range was 25 to 50, whereas the majority falls in the range of 40 to 50 years, and majority of them were female. As per qualification, most of the study participants possess BSc, post-RN BSc nursing degree, and in designation, the nurses, clinical nurses were 41%, whereas 59% were clinical nurse leaders. And the experience was 16 years as in mean. The key themes derived from this study were perception regarding mental well-being, factors affecting mental well-being, consequences of disturbed mental well-being, coping strategies the nurses are using, and what are they suggesting to the organization to make the to make the mental well-being sustainable. So I will describe one by one. The perception regarding mental well-being derived 4 further themes, which include significance of mental well-being for nurses, balance between professional, personal, and social life, satisfaction with personal life, and managing self. So mental well-being is a crucial phenomena or a factor to contribute safe and quality care of their patients. One of our nurse participants said, if you are not mentally well, how can you provide care to others? One cannot be good health professional and cannot provide quality care if it's not mentally healthy. And the phenomena was supported by Cherry et al. Well-being is an experience of positive perception and the presence of constructive conditions around someone. The second sub-theme was balance between professional life, personal, and social life. One of the participants said that well-being has 2 aspects. One is how a staff is adjusted to the workplace, and the second one is how their family matters are going on. If we do not take care of all these simultaneously, we cannot maintain their mental well-being. And one of the participants said that if we are mentally disturbed, inactive, or aggressive, may shout out someone, we may create the problem in the environment. This phenomena was also narrated by Suhaili et al. That it's important to have professional, personal, and social life balance for nurses to have positive well-being. In the same theme, a sub-theme was satisfaction with personal and professional life, and one of the participants stated how one can take care of self, like exercise, eating habits, sleep pattern, etc., and maintaining the relationship and managing the stress is a well-being. And then Cherry et al. Has supported it that well-being is a positive perception and a presence of constructive condition around someone who is working in nursing organizations. Next theme was about factors which are affecting nurses' mental well-being at workplace, and it was emphasized that there are a range of workplace factors that shape nurses' experience, and they create psychological strain and emotional burden. So the nurses described different sub-themes. The incompetence is not only increased stress, but also lead to the fear of errors and apprehension about repercussion. This was the theme emerged. Our participants said someone with lack of competence is unable to provide required care and may commit mistakes and hide them due to fear and consequences and attached with that. And that will cause huge stress and affect the mental well-being of nurses. And another participant said that if staff is not competent, patient care can be affected and their performance can be affected. Likewise, Rees et al. Also emphasized that for nurses to work with confidence and to be stress-free or relaxed at workplace have to have a competence. Factor affecting well-being identified recognition and appreciation as a substantial source of lack of recognition and appreciation as a substantial source for distress and affect negatively staff morality and motivation. One of the participants stated, if one is not appreciated, then they leave the organization. So I suggest appreciating good work and behavior of the staff as a factor. And another staff said, I feel stressed when my senior looked at me, overlooked at my efforts and focused only on criticism. Halton et al. In their study, they've illustrated that leaders who support autonomy and encouraging nurses' independence and address core psychological needs significantly boost intrinsic motivation, resilience, and job satisfaction. In the factors, inadequate care coordination among healthcare professionals and different department was also found a factor of stress leading to poor mental well-being. And the literature has supported that care coordination among the department and healthcare provider is very important for a smooth functionality as well as to reduce stress in the environment and produce a healthy work environment. Working hours and shift schedule affect nurses' personal social lives and the organizational policies standards further contribute to it. So one of the participants said, this hospital has different standards, policies, work expectations, workload, and quality indicators. Therefore, new nursing staff feel stressed, but this stress diminishes with passage of time. So this response was spotted by Montgomery et al. They said when job demand exceeds available resources, burnout and disengagements are likely outcomes. The third theme was what consequences can occur due to disturbed mental well-being. And the nurses have identified that mental well-being is interlinked with provision of safe and quality care. A participant said, when someone is mentally unwell, their capacity to work will be limited and the stress of work expectation may further drain their energy, leading to compromised patient care and patient harm. Another participant who might be working in an area of high alert medication administration was worried about making mistakes and causing harm to the patient. And Melanick et al. Also found that nurses need to be relaxed, mentally healthy, and need to have a sustained mental health if you want them to work in a safe and quality environment. In the consequences, nurses found that for healthy and productive work environment, they need to be relaxed, stress-free, and mentally healthy. Likewise, one of the participants said that mental well-being directly affects the interprofessional relationship among nurses, the patient, and colleagues. A satisfied staff benefits and enjoy benefits and appreciation for his work, and it cause positive effect on working environment. Whereas poor communication reduce empathy, decreased focus on work, and these responses were also found in the literature supported by different authors. Disturbed mental well-being also cause effect on performance and productivity of the staff. So staff mentioned that the staff who is motivated, a motivated staff perform a task effectively and efficiently as compared to the one who is demotivated. Similarly, they say it has a deep relationship with performance because someone who is mentally relaxed can perform the given task smoothly. And the literature in different studies supported this response. So in the disturbed mental well-being, they expressed that disturbed mental well-being can be manifested into psychological and behavioral change, which has to be addressed. Otherwise, it can lead to the serious mental problems. The participants were asked what coping strategies are they using to combat the problems, to manage their stress, and to stay healthy. So again, they said maintaining competence in professional practice is one of the coping strategy they prefer to. One of the staff participants said they should be competent in their nursing skills. This will make them satisfied and help them to avoid stress. And studies also support that. One of our participants said that there is always stress in the beginning, but I have learned with the passage of time and experience. A significant dimension of coping strategy was use of emotional intelligence and self-control. And one of our participants recommended or suggested us, you do not lose your emotions, encouraging others to remain composed, demonstrating both self-awareness and empathy towards challenges. And I will tell him or her to stay calm and not be stressful. Another participant mentioned that sometimes emotional conditions make it difficult to manage your stressors and control your thing. So Karimi et al., Hedri and Ibrahimi also supported the phenomena that one can manage its stressors by emotional intelligence and self-control and can stay mentally healthy. Monitoring staff well-being by the organization, by the leaders, supportive supervision, and ensuring a positive work environment were emphasized by our participants. One of our participants said, I appreciate them verbally. My staff feel that the team leader is at my back. Supporting someone in their work is a good appreciation. Likewise, another staff said, they need someone to talk to, and by talking and listening, we release our stress. And Shanafelt and Nosworthy also supported that people who ventilate their stress and they have support from someone to manage their stress can manage their mental well-being more appropriately as compared to those who keep things to them. Then we asked the participants to suggest how organization can help. Workplace practices and policies can be further improved, and how the satisfaction and well-being can be enhanced. And we found another 5 sub-themes in this perspective. So the participants believe that recognition and appreciation is a fundamental element in sustaining mental well-being of nurses. Rewards matter. One of our participants said, appreciation gives me energy to work hard. Patients' recognition motivate us to stay accountable. And this response was supported by Yi et al. That recognition and appreciations are critical component of healthy work environment. They are directly related to job performance, lower burnout, and improved care quality. Another suggestion was to improve our professional growth and educational development, which was emphasized by our participants of the study. We should encourage staff to go for further studies like post-RN and MSc nursing, because providing opportunity for professional growth, reduce stress, and promote positive work culture. And Ching et al. Also advocated that professional growth bring confidence in clinical skills. Competence not only enhance confidence, but also foster resilience against occupational stressors and sustain the mental well-being. Another strategy or suggestion which was emphasized by the participant was significance of a psychological, safe, well-managed environment. And the research supported that cultivating a positive work environment, providing support, caring leadership style, promote positive attitude and work behavior among nurses. Like other studies, these studies have limitations and strengths and limitations. In the strength, I would say the study have given a rich information about the phenomena because it was done trust-wide nurses working in oncology setting. Heterogeneity of the participants' experience, qualification, and their role in nursing also have enhanced and added to the body of knowledge. And in-depth interviews help us to have a deeper understanding of the phenomena. Whereas in limitation, because the study was done in cancer setting, in nurses working in cancer setting, and cancer setting have its own care paradigm, which is different from general setting. So perhaps transferability of finding to the other context may be limited. And face-to-face interviews may have affected expression of responses by the participants, which may have been still hidden and not come to the surface. Interviewer bias in interpretation of the responses of the participant could be one of the limitations. So in the end, we will recommend that phenomena of mental well-being has been established, but further studies can be recommended to explore empirical evidences and factors affecting nurses' mental well-being and the intervention to meet that. The nurse leaders should review and perform leadership and management approaches by shaping day-to-day work life and settling the culture and tone of workplace and doing role modeling. Nurse executives who have influence on the organizational policies, they may advocate for staff benefits and they address staffing and scheduling to manage the issues on workplace. Existing support system of the organization, which was acknowledged by the participant, can further be strengthened by regular psychological briefing, emotional resilience training, and peer support group. Open door communication policy of the hospital can utilization of open door communication policy of the hospital can support foster the supportive environment. And we can introduce different model for those and opportunities for those who are interested to have a professional growth, go to the universities and study further. Flexible roster can be provided to young nurses who are young mothers who are working with us as nurses and those staff who are studying in different universities while working. So in nutshell, nurses' health and well-being are affected by external environment, organizational structure, policies, and condition of day-to-day work. Poor mental well-being in nurses lead to negative effect like increased medical errors, reduced quality of patient care, higher turnover, and burnout. These issues can strain nurses. They can affect their personal lives, they can cause their social withdrawal, and they can cause difficulty in self-management. Improving mental well-being of nurses is multi-level and multifaceted approach that addresses their holistic health and creates safe, supportive environment for nurses to work smoothly. Addressing stress and mental health issues through reforms aim at changing workplace policies, culture to support the well-being of nurses, and ensuring their capacity to perform at their level best. So thank you very much for listening me with the patient. We have used these references to support our study. The study was approved by Scientific Review Committee of the institution and Institutional Review Board, and all the data was kept in the confidentiality. Thank you very much.
Thank you, Ms. Rehana, for sharing with us the nurses' experiences. Indeed, your study findings and the published literature both supports providing a conducive working environment. Appreciation, recognition, and support and mentorship are crucial in improving the nurses' mental well-being and ultimately improving the patient care and safety. May I now request all the speakers to please come forward for the question answers. I believe Dr. Angel is online for the question answers. Hafiz, can you check?
If there is any question, so we have there's arrangement in the middle of the area where you can come and ask question. Okay, so if so, can I start? Okay, Acha chalo. Okay, Basharat first.
Can I?
Yeah.
Assalamu alaikum. So my name is Muhammad Basharatullah. I'm from Shifa International Hospital, Islamabad. Congratulations to all the speakers. But I particularly want to talk about AI, which is today's buzzword, and whether we are at a novice level or senior nursing leader. We are all at the same level, and there's a huge knowledge gap. So the question is that what we can do immediately on a short-term basis and what can be done on a long-term basis to fill this knowledge gap so nurses can use AI ethically and responsibly, not only use, but also be a part of training of the large language models and in creation of the AI tools.
May I answer this
Sure.
very succinctly? The short term is, that's why we had today 2 speakers to talk about this topic and educate us, share their experience.
Yes, that was excellent. Yes.
In the long term,
Hmm.
we are demonstrating readiness to listen to them and to collaborate with them. So I think that will help. Thank you.
Thank you.
Yeah, please.
Thank you for your question. I ran out of time to talk about nursing education at the very end, and tomorrow I will speak more about the resources that are available to educate nurses about AI. So the session tomorrow morning, I will speak more about the AI Nurses Network. But in my university, I am teaching our undergraduate students the basics of AI, a little bit about machine learning, a little bit about NLP, how to use ChatGPT and some of the large language models. And I know Angel is doing something similar in her university. So slowly, if we all share our resources, our teaching resources with each other and help our nursing faculty teach our students and our practicing nurses, I think we can all really benefit in the long term. So thank you.
Thank you. Thank you so much.
Angel, would you like to respond?
Sure. I agree with everything that's been said. Can you hear me okay?
Yes, we do. Thank you.
Okay, great. Yeah, I agree with everything. And I also just really think the eagerness to be involved is fabulous. And there's going to be opportunities. This is still really new, the integration of AI. And so I just think to learn the basics, like we were just talking about, but then be ready to jump in and participate when there are opportunities to learn more about AI-based tools, to teach others, and to have a part in the implementation and then like the human oversight of it. Thank you.
Yes. Yes, Fozia.
Assalamualaikum, Fazia here. So my question or like appreciation towards Dr. Raisa. So I like, I feel very proud and to see all the Pakistani references in your slides. So this is very good change. Thank you, ma'am. And I want to like ask how to improve the nurse's attitude towards the cancer patient and family care.
Hello. Hello.
We can hear.
Thank you very much. Think attitude is, as we are saying, that is the affective domain. And I think it will be very pertinent to tell you that one of my master student, in fact, she's presenting her findings at the University of Lahore. And we looked at it that how affective domain is integrated in our curriculum. Starting from, what is the interpretation and meaning for nurse educator? How they integrate it and how do they assess it? I cannot tell you all the result,
Okay.
but just 2-3 highlights. Everybody states that it's very significant for nursing. It's like the foundation of nursing. It's humanistic requirement. And I think all of us expect, if we want to see ourselves in the patient shoe,
Agree.
that's what we agree. When it comes to teaching, unlike the cognitive domain, we feel we are incorporating it in our teaching. And for assessment, usually it's all, subjective assessment. And we think it is part of the cognitive or the psychomotor. So I think one thing is that, this study will also help us that what we can do to really give its due importance and how in a systematic manner we could integrate that in our education. Thank you.
Thank you, ma'am.
Thank you. So we have all the speakers available in the symposium, and you can have your questions while you are there in the lobby. So thank you very much.
I'm sorry everyone, we are running a bit late. So I would request that जो पहले वाले session वाले थे, if they could leave and the new ones can be seated so that we can catch up.
मरियम किधर है? मरियम ने सभी रेडियोलॉजिस्ट भी नहीं. So, Assalamu alaikum and good morning, everyone. I welcome you all to the 24th Shaukat Khanum Cancer Symposium, and we are going to conduct thoracic oncology session today. So, basically, oncology session, we have interactive cases so that we can have a discussion. As we still know, lung cancer is something which is a challenge in terms of their treatment and the limited treatment options which are available. So I would like to invite my panelists on the so my first panelist is Dr. Kamran Rashid, everybody. So I would like to invite you. He's a consultant medical oncologist and doing lung for a long time. So I would like to have Dr. Kamran Rashid, Dr. Sameed, and Dr. Adnan as a panelist member. We have Dr. Amna Hassan in our panelist session as well. I think in the limited seat, I would like you to have a seat here and then we have an interactive discussions. So I'm going to start with the case 1. So case 1 is a 46 years old male smoker with 4.5 pack years history of smoking with no other major comorbidities, presented with cough for last 1 year, chest pain for 2 months and 4 kg weight loss. He had history of hemoptysis for last 2 days. He does not have any significant past medical history. On examination, there was no critical finding, and the performance status at presentation was 1. We have our colleagues and trainees with us. So if any patient who present with this, what comes the first differential in the mind that what the patient is suffering from? Anyone from the resident can come to the mic and give their differentials. Subhan, you can come to the mic and give your differentials.
Doctor, sir, can you please make दरवाजे बंद करवा दें?
Ji, I think
Okay.
anybody can just close the doors, please, so that we can have a quiet space here. Yeah, sure.
Okay. Assalamu alaikum. Myself, Dr. Subhan, resident in clinical and radiation oncology. So we can include in our differentials like tuberculosis, carcinoma, in which we can say it's a laryngeal carcinoma or lung carcinoma, okay? And maybe it's maybe an infectious disease, or that's fine.
Yeah. So this patient had a complete staging workup. We did the EBUS FNA of the node and the primary. Dr. Adnan, I would just like to ask you some questions regarding how difficult is that for EB ultrasound to have their biopsies for the primary and the nodes?
So with this EBUS FNA, we have 2 purposes. One is to get a diagnosis, and the other thing is we do the staging at the same time as well. So that is achieving 2 goals with 1 procedure. And usually it's a very safe procedure. We do the procedure the same day patient comes to our endoscopy, get that procedure done and can be discharged on the same day. And usually we don't see a lot of complications. And the good thing is that we have our rapid on-site evaluation of our sample as well. So we get the initial results on the same kind of setting. The pathologist tells us whether the sample that we have taken is adequate and if we have are in the node or not. So that saves us doing a repeat procedure for that patient.
Yeah. So the EBUS FNA of the right bronchial mass turned to be adenocarcinoma mucinous type and favoring the lung origin as it was TTF1 positive. So the staging workup was being conducted for this patient. On the biopsy specimen, we also performed the PDL1 testing, and which was negative for this patient. The MRI brain was done, which showed small focus of the right parietal infarct, but no metastasis. Apart from, we as all know that apart from PDL1, we also would like to have an EGFR mutation and ALK mutation testing for these patients. So EGFR 18, 19, 20, 21 was wild type, and ALK mutation was also not detected. So this patient had a PET CT, and I would like Dr. Amna to just have a look and comment briefly about the images.
So the primary mass is hypermetabolic. So the orange stuff is what I'll call hypermetabolic. That means that the tumor is metabolically active. We have two differentials, which would be infection or tumor, but given the clinical context, and in addition to the lesion in the lung, you have lymph nodes in the mediastinum, and then you've got a lesion in the bone, which lights up on the lower left for you image.
Yeah.
So yeah, it is a T3, N3, M1C.
Yeah. Yeah, so the stage for this patient was T3 and 3M1C, as this patient has a primary tumor in the right side along with some contralateral nodes, and there was ever disease in the bone as well. So the stage for this patient is again T3, N3, M1C. Just reiterating the immunohistochemistry marker, as we know that PDL1 was negative in this case, along with the EGFR and ALK, they both are negative. So oligometastatic disease. So I would like to ask the questions for the panelists, Dr. Kamran and Samid. Any further staging workup?
I don't think so. It's complete. Yeah, you have a CT, MRI of the brain and a PET scan. That's good enough. I think so.
Yeah. So we don't need any further investigations like bone scans for these patients because we have a PET CT which showed that it's a metastatic disease. So my next question with Samid is your thoughts about having NGS or further immunohistochemistry markers, despite of the fact that we have 3 done.
I think in Pakistan, we have the therapy available for the markers that you have already done. So that's pretty much it. One more is ROS1, which also have the same therapies as the ALK positive therapy. So that can be done, but going for NGS depends on your socioeconomic status or the insurance status of the patient.
Yeah.
Ideally, you should have, but again, many other factors need to be counted in.
Yeah.
Just one, add one. See, sometimes you have these rare mutations.
Yes.
I had a patient who just recently saw adenocarcinoma. We did the full panel NGS, and the patient had RET mutation.
Yes.
So if you would have checked for ALK, ROS, EGFR, we would have missed the mutation. So if somebody is affording, I again and again tell my residents and my trainees that always get the full panel, whole NGS sequencing. Because sometimes you find some, and these mutations, these patients can have very dramatic results with just oral pills, for a very long time. And these rare mutations, these drugs are very, and these drugs are available in Pakistan. For this patient, Serpal Captain, that's from Bangladeshi origin, we arranged it, and the patient is taking it for a couple of months without any chemotherapy now.
Yeah, I completely agree. And I would say there are even the mutations other than 18, 19, 20, and 21 for EGFR, there are rare mutations coming in.
And sometimes what happens is that you don't have any therapy available for the target you identify, but you never know in 3 years' time, like in prostate cancer patient, you can have this in 3 years' time, a target may be available. sorry, a therapy may be available for the target that you have identified.
We have a question as well.
So if sample insufficiency is there, so what's the what to be done next? So
Blood-
repeat sample or
blood NGS can be done. So what you can do is you collect the blood, give it to the foundation, and they can look how much cell-free DNA is floating in the blood. If they have enough cell-free DNA, they can run the sample. It's pretty much concordant. There's a difference of, I believe, 5 to 10% between the sample and the blood. So in lung, doing repeat biopsy, see, in the West, they're doing repeat. Once the disease progresses, they do a new NGS, thinking that the patient might have acquired new mutations. So obviously hitting the lung again and again, the chances of pneumothorax, it's a difficult procedure. So if the blood has cell-free DNA in it, I believe you can do a lot of NGSs in the future on the blood.
Yeah, we will come to that, Dr. Kamran, as well. So what about the timings for getting these results? Because we all know these patients are poor performance status, locally advanced disease. Being an oncologist, we want to relieve their symptoms as well. But in an era where we have a lot of mutations, so what's the normal reporting time or waiting time for these results?